happy today to have Dr. Isabel Amigues on the Arthritis Life podcast. Welcome.
Hi, thank you so much for having me. I love what you do.
And you too. It's one of these things where we've known each other on social media and now we're finally talking in real time. So just as a quick introduction, can you let the audience know where you live and what is your relationship to arthritis?
Oh, yeah. So I live in Denver, Colorado, in the US, and I am a rheumatologist, and I'm particularly specialized in rheumatoid arthritis. First, I did a lot of research in rheumatoid arthritis and heart disease. And then I moved to Denver and I did a lot of research in interstitial lung disease and rheumatoid arthritis. But yeah, and I love all rheumatology, to be frankly honest. Anything inflammatory.
Yeah, well, you perfectly led me to the next question, which is why did you choose to specialize in rheumatology?
Oh yeah, I love that question. It's like one of my favorite questions. With the what is rheumatology? And I'm like, oh, Dr. House without the attitude.
Yeah, without the adjective, exactly. Dr. House with much more better bedside manner.
Yeah, yeah, or a different type of attitude. But so yeah, I discovered rheumatology in France when I was a medical student and then a resident. And I think it was my second training rotation. And I fell completely in love. But because it's, the first or second rotation, I didn't make much of it because I tended to just like everything that I was exposed to. But I kept going back and I kept going back. And at what point I just remembered, and I just realized, I was like, every single disease that I like are inflammatory. Like I like systemic disease and I like when it affects the whole body. And I really like the thought process. And then I finished my residency and my fellowship in France in rheumatology. And then I moved to the US and I repeated my residency and had the choice of changing specialty. And I could not imagine being anything else than a rheumatologist because I had started experiencing what it is, which is that I always say this. I say in rheumatology, you have one third, one third, one third. One third of patients that are undiagnosed. And I love that part. Like I really feel like Dr. House, and I feel very privileged to have had two trainings because I feel like I'm very clinically oriented with a research background. So it's kind of like this really cool thing. So one third are undiagnosed. So it's very like intellectually stimulating. One third is actually sort of easy bread and butter rheumatology, which is, easy rheumatoid arthritis. Not every rheumatoid arthritis is easy, but there are some that are very like straightforward, or easy gout or easy ankylosing spondylitis, And then there's one third where it's sort of, well, we have to deal with what's going on with the patient. So maybe they do have rheumatoid arthritis, maybe they do have ankylosing spondylitis, but there is other stuff going on. There is maybe fibromyalgia associated, maybe there is chronic fatigue syndrome associated. And so then it becomes this, real work as a physician that's not just a technician, but also like a human being. Like, okay, how do I get you to feel better? How do I get you to be in your best health, working with you and helping you, empower you. So there was that. And then at the end of the day, one of my favorite thing about rheumatology, other than, what type of disease am I going to encounter? What type of patient am I going to encounter? It's basically this relationship with the patient that's, like a lot of my patients are lifelong patients. And I even have patients that I met when I was in New York City when I did my second fellowship that are still in contact with me. And it just feels good. I feel part of their family. I feel like they are part of my family. And so that is something that I, really cherish, this relationship with my patients. So that is why. Twice.
I love that. Well, yeah. And I feel the same way about my rheumatologist. I've been so lucky that I've had her in my care for over 20 years now. And, I invited her to our wedding. Like she is truly an important part of my life. And it is, as you were trained as a physician, it is one of those things people think about, like, do you want to have that long-term versus like maybe emergency room where you might see lots more patients in your lifetime, but only see them for a short period of time versus rheumatology. So, and I always say this, but because I interviewed one of my very first interviews I ever did for Arthritis Life. It was before the pandemic. It was in person in Seattle with a rheumatologist, not mine, but a different one. And he said, I said, why did you go into rheumatology? And he said, the diagnostic dilemmas. He really likes the mysteries. And I always said, even though I'm so passionate about rheumatology and I love, working in this field as an occupational therapist and a support group leader, I actually would find that I feel like I would find it really stressful.
Oh, really?
Because I have a low, my therapist said, one of the things we work on is ambiguity tolerance, like tolerance for those unclear, like black and white. So even though my role as helping support people in managing their condition, I don't mind the ambiguity of that, but having the responsibility to make that diagnosis somehow seems really intimidating to me. Like,
yeah.
What if you're wrong? What if it's lupus? What if it's, but I guess you just learn to be flexible, right?
Mm-hmm. And so something I learned in France is, there's a lot of value from having done this dual training. So I saw your face and you were like, what? You had to do 2 trainings. And I see it as a luck, right? Like some chance, because like not everyone gets to not need to be productive forever. And I remember I was doing some research at Sloan Kettering when I wasn't completely sure I would do rheumatology. I came to the US and I did some infectious disease research. And I remember this doc, super well known. I think he created the Shingrix vaccine. And he said, as fellows, and he was talking to the other fellows. I was a resident at the time in France, so like well before I came to the US, and he's up for good. He said, fellows and residents is the only time where we are not asking you to be productive. And I remember like so clearly, and I was like, wow, this is so valuable. And he's right. Once you're an attending, you have to be productive. You have to see a certain number of patients. As a fellow, you're asked to learn. And so I was like, okay, well heard. And so that is actually one of the reasons I had no problem repeating my residency, no problem repeating my fellowship, extending my fellowship, because I was like, as much as I can learn, I'm learning. And I still learn, of course. You still learn so much as an attending, but like at the time, I was just like, yeah, my job is to learn, and I love that job.
Oh, that's amazing. No, and I do think that, people self-select into the medical specialties as much as they're able to. I know you can't always control where you're placed and such, but into the, specialties that work for them. And so, yeah, I always, I find rheumatologists to be some of the most, really holistic, caring, I don't even know what to say,
Yeah.
they're kind of known as cerebral, like very like, kind of nerdy in the best possible way, as a compliment. I mean that. And so, and on the topic of learning, I think a lot of people who listen to the podcast, we have a big range of people. There might be people who are newly diagnosed, or like a family member or a friend of somebody with inflammatory arthritis, which when we say inflammatory arthritis, meaning like the, rheumatoid arthritis, psoriatic, ankylosing spondylitis, the kinds that are autoimmune. And then we have people who've been living with it like me for 20 years. So we have a big range. But something I've noticed is a lot of people are confused about what remission means. When you live with one of these conditions, even if you had it a long time, like I have to be honest, I had to look up, like, what is, it seems like everyone has a little bit of a different definition. So can you tell us a little bit about like, what does remission even mean? And then we can delve into some more specifics.
Absolutely. So I think the first and important question is why we came up with that term and what it means. And so I think we talk about disease remission in rheumatoid. I'm going to talk about rheumatoid arthritis because it's the one that I've looked the most. And when we were starting to look at the term remission, it was associated remission/minimal disease activity. And that happened around the time that we started realizing that we need to have, so at first they were calling it treat to target, and then they called it drug to target. And it really started with the advent of biologics. And so basically, then, I'm a nerd. Clearly, you said it, and that's true. But I love the history of rheumatology. Like, it just, when you actually go deep into the studies, you start learning about how we are making the decisions that we are making today. And so before, when we didn't have all the biologics that we have, we used to do a step-up approach. And so you would start with anti-inflammatory. Then you would add maybe methotrexate. Then you would add sulfasalazine. Then you would add, leflunomide and so on, or plaquenil or so on, like depending on which one had been shown to prove something. And they were doing this step-up therapy. And then there's a couple of trials, including something called the SMART trial, where they found that starting with a bang had more chance of putting patients into minimal disease activity and remission. And then because we started having more patients in so-called remission, and I'm gonna define it, then we started defining what disease remission is. Okay, so it sounds like we should have defined the disease remission before, but it really started after, because until maybe 20 or 30 years. I'm old now.
Well, yeah, I was just looking up. So the first, because I always forget if it's the late 90s or early 2000s, the first biologic was approved in 1999. So
Yeah,
it's like, and
99.
I actually am really glad you're going into the history, and because I encourage people to look at the history to understand, because it helps you be less fearful about the medications when you understand that the disease before the late 90s and early 2000s, this disease, it's a progressive disease. We didn't have, the medical field didn't have the tools that we have now to put it into remission. So I think I'm glad you mentioned all that.
Yeah. No, and I think it's important to realize that this concept is fairly new, right? So the SMART trial, I think, is like 2003, 2005, something like this. It's like it's much later. It's right, like first we're putting biologics, then suddenly like people are like the people we were putting on biologics, so the TNF inhibitor, they were the worst. They were the people with the worst disease because we didn't want to use those for anyone. And it's only maybe 10, 15 years later that we realize, like, what are we doing? We should put patients on biologic as fast as possible if they do not respond to the first line, because we can get them to remission. And at one point there was this concept of what is disease remission. So disease remission in studies is no more pain, no more swelling, no more joint stiffness. And so really when you're thinking about it, it's like, wait, what? Oh, so I have no more pain, I have no morning stiffness, and I have no more joint swelling. I am in remission. You may still have a little bit of fatigue. You may still have pain all over your body if you have, small fibers neuropathy or fibromyalgia. But normally, no more joint pain, no more swelling, no more morning stiffness. That is what we call disease remission.
In the clinical studies.
Yeah, exactly. And in associated with it, there is the minimal disease activity, which when we say we're drug to target, we are aiming for that. We're aiming for, so this is really funny. You can have one painful and or swollen joint. That's it. One.
Yeah.
One. That's what I tell my patient. I'm like, anything more than one, I'm not happy. I'm not happy. And I'm talking about rheumatoid arthritis. So that's really important because unfortunately, we're not yet there in lupus. We're not yet there necessarily in vasculitis. We're not yet there in psoriatic arthritis. And we are aiming and we could get there, but it's not as obvious, I would say. So then, those studies show, like once we had enough patients that went into this minimal disease activity and disease remission, then, the sky is the limit. And so then physicians were like, okay, well, what can we get? So yes, we can get disease remission. Can we get cured? And so that's a very different story. Cured means that you don't have any treatment to achieve this disease remission. There's like no evidence of active disease. And unfortunately, so far, not great. We cannot say cured. And honestly, like I would say that the vast majority of my patients have no problem with that, because as long as you live a completely normal life, it's just etymology, right? It's just a word.
Well, and I think that brings up the point of, is it medicated or unmedicated remission? So I often tell the story about, I was extremely lucky, I think because my RA was so aggressive and severe at the point, or just clouds aligned. I don't know what happened, but in 2003, I was put almost, I wasn't able to do sulfasalazine because I had a allergic reaction to it. So then I was immediately put on methotrexate plus Enbrel, and I went swiftly into remission. Like it was night and day. Like I couldn't open my hands from a fist, and then I was playing soccer again and running around. And, I injured myself swing dancing the next year. I mean, I was running, leaping through the fields, and a lot of people, anyway, side note, people often make fun of the drug commercials, but because they're like, not everyone's like running through a field of sunflowers, but I'm like, but it's not inaccurate to say that some people are. And so, but point being, so that was, but I still had to stay at that point. The thought was, and I think it probably depends on the patient now, to stay on the medicine. I know some people now are able to get into unmedicated remission. So there's medicated remission where you're still taking your medicine for your rheumatoid arthritis. And then unmedicated is where you're maybe often you slowly wean down and stuff like that. Can you tell a little more about that?
And so when was it? In the early 2000s, 2005, around that time, there was a whole, again, like this is just the history of rheumatology. Like I'm lucky that I've got, 2 trainings and I'm very interested in that. But in the mid, like 2003, 2005, 2006, something around that time, basically we started wondering if we could cure patients. So what happened is that there is something called the early RA, which is the window of opportunity. And so our question was, can we put a patient in remission and then cure them by treating them early? And we were so hopeful, but so far not super exciting, not as exciting as it sounds. And it looked like, yes, there are some patients who are going to develop something that looks like rheumatoid arthritis that's not necessarily rheumatoid arthritis, and you may start them. And in France, we were pretty lenient in giving biologic. If methotrexate didn't work, you would put them on a biologic, and then they would not need it. But the question later on was like, was this actually rheumatoid arthritis the whole time, or was it just some sort of reactive arthritis that responded to TNF inhibitor? So all this to say, I think that aiming for remission is a really cool goal because it allows you to have a totally normal life. And the only time you remember of your condition is when you have to give yourself the medication. And so that's fair. Like, it's not really a big price to pay unless you have complications with the medication. And then we can talk about that. But, this concept of cured, unfortunately, in rheumatoid arthritis, I think it's really hard to, I think that some patients, if you take them really early, you can maybe decrease the amount of medication that they need. But I don't know that I've had anyone that has not needed medication. And like over the years, maybe for a year or two, they don't need it, which is great. And, like sometimes I have patients that need like one injection, or one infusion, like it's very little. And we work. And then there's like all of those anti-inflammatory things that you can do. And that some patients are so into, meditation, relaxation, and exercise, anti-eating and anti-inflammatory diet. And I'm all for it. All for it.
Sleep is the one I always talk about.
Sleep. Yeah, exactly. But, it depends on who you are. Like, and I will be honest, I've seen some patients who don't need any medication on this. I'm usually there just in case. But so it does happen. And I've seen patients even with high CCP be in what we would call cured. I just consider it remission because I never know when, and at the same time, I don't want them to freak out and to feel like it's going to happen at any time, like a disease is looking, when am I coming back? Because again, we have amazing treatment. So it's not, I think that living, for me, like I want my patients to live the most normal life as they can without fear, because this is such a known condition and we have so many options now.
Right. Well, and I think it's funny that you've used the phrase normal life. So, because I one of my first podcast episodes actually was, can you live a normal life with rheumatoid arthritis? And the only reason I actually thought about that title is this is episode 29. So I'm going to put a link to it in the show notes. But is that, so we're going to go on a little tangent, but we'll go back to Remission. But is that I actually discovered that I had a blog called theenthusiasticlife.com, and I somehow got onto some of my analytics, and it said, what are the search phrases on Google that are leading people to your website? And one of the search phrases was, can you live a normal life with rheumatoid arthritis? And I think this is just my perspective. I think that, it really all depends on what is your definition of normal, right?
Yeah.
If you put your definition of normal as a life where you never have to think about health and go to the doctor or anything like that, like, no, for me, that's not my life, right? And I sorry, I'm trying not to like summarize this without like rambling on forever. But the point is that like I do think this is maybe me being like a liberal arts undergrad student, but I do think that like sometimes the phrase normal life rubs me a little bit the wrong way, in the same way as like having as long as the baby's healthy can kind of, I'm not saying about you saying normal life, but just in general, because it's like, oh, well, not all babies are healthy and they still are 100% like worthy of, love and respect. Of course, we would all wish to be healthy, but we're not. And so not everyone's healthy, and they can still thrive and still have like a wonderful life alongside their condition. So that's kind of the conclusion I came to in that episode was, acceptance and accepting that this is part of my life. And I know this is very congruent with how you see things too. So I'm not saying,
Yeah.
I'm just bringing it up.
Absolutely. I think that I was talking to you about the three type of patients, right? Like and it's really I say three type of patients, I could say three type of conditions. First of all, I use the word condition because I think condition, right? So you're working with versus of disease, which is like something that doesn't, like you're not in ease.
I like that.
Yeah. And so condition has this idea that we're working with it. And so as someone who had cancer, I realized that the way that some docs were seeing me did not work for me, and the way that some people saw my disease did not work for me. And I did not want to feel that I was having some sort of enemy inside of me that was ready to kill me. I didn't know if I would make it or not. The thing though is that I didn't want to fight, and the idea of fighting means that you're spending all of your energy against your body and against this disease and against your body, when really what it is to me, and from my own experience as a patient and my own experience as a physician and with my own patient, like I see the role of a rheumatologist to help my patient. But at the end of the day, I'm just helping in the sense of like the patient is the one walking with this condition, and they have, how to explain this? They are working with it, and they have to listen to their body. What works for them? What doesn't work for them? What do they need? What do they not need? I can only offer my expertise from research, from my own experience. But at the end of the day, like the patient is living with it, right? And so it's with it. And so normalcy is really difficult to define, because I think like every single person has something that they're dealing with.
Right.
And so, I mean, the number of people around me, I do like meetings where I invite someone and I interview someone from my community that I find interesting, and the number of things that you would not know how much everyone is not normal in that definition of what is normalcy, right? So yeah, we're all normal and we're all abnormal because we're all so unique. Yes. And so I think, to come back to this, I think that seeing rheumatoid arthritis, since that's what we're talking about, as an enemy that you want to get rid absolutely at all costs is just going to put so much energy on something, like instead of putting this energy towards healing and towards caring for yourself and for your body that's trying to do its best, and instead of like working with it, we're just like fighting. And so like that's like, it's funny, I actually gave a TED talk about that, because I was like,
Yes.
we have to see our body as this, this like, I don't know, like all of those cells that are trying whatever they can, to help us. And
I think,
sometimes they need
yeah,
help.
I know I'm really into the language of this, and I'm 100% congruent with you. I do sometimes use the phrase like warrior, like rheumatoid arthritis warrior, because it's really common in the social media like communities. But yeah, I feel like the warrior, I'm metaphor applies to me with my athletic background of thinking about like, even though I'm tired, like I'm gonna like get my energy together, and I'm gonna like fight for the life that I want, not necessarily fighting against, my body. So I think that's a really beautiful way to see it. And I do think when most people say, I want to live a normal life, it's really a shorthand for, I want to be able to do the things that bring me joy, the things that are
Yes.
meaningful to me, and that used to be actually the definition for occupational therapy, or the tagline was like helping you live life to the fullest, or helping you engage in meaningful activities. I'm like, it's so amazing that there's a whole field devoted to that, So anyway, I'm
Yeah.
always like giving a shout out to occupational therapy.
Yes.
But yeah, so there's different ways to enable people to engage in meaningful activity. You can do it through the medication that gets to the source. And obviously that's a big part of my treatment toolbox, but you can also do it through the lifestyle alongside that. Like you mentioned, mindfulness, stress management, and then investing in, and then, yeah, whatever gives you the biggest bang for the buck. Nutrition for some people, nutrition doesn't seem to be as big for me as like sleep and stress management and exercise. I recently added weight training to my
Nice.
toolbox, and it's been having a really positive effect. Actually, not necessarily on the pain, but on the brain fog and fatigue. Super interesting.
Yeah.
And also just seeing yourself as like a whole beautiful person worthy of love and self-compassion,
Yeah.
and despite having this diagnosis or alongside it. So I really I definitely think, and it's a helpful analogy. And I think your experience as a cancer, I don't know if you want to say a cancer patient, or your experience having the condition, cancer, has really given you a really unique perspective, I think.
Yeah, no, absolutely. I think that I was open to it, and then like, just walking in the shoes, right? And then continuing. I really like what you're saying, which is, and it's really interesting. We're almost in metaphysical questions here.
Yeah.
Who are the people, to come back to the difficult, like the patients with difficult to treat RA? And so, we had this debate on social media, which is not the best place to have a debate anyway. But I felt judged by, not by you necessarily, but I felt judged by my community. Like, how come I'm aiming for disease remission? Why am I saying this to my patients? And I'm like, well, number one, because I know we can get there. And number two, why should I be afraid to say that I'm aiming for that? And it's really interesting, like so to go back to, there are some patients who are difficult, like it's difficult for them to achieve this disease remission. So I aim for disease remission in all of my patients. And even for me, I want disease remission,
Yeah.
I think what's really interesting is, and I have some example, and we can go into the research if you want, but I think that examples are stories, and stories are so more impactful. So I'm going to share a story that I shared in my TEDx talk. Yeah. So I called this patient Mike, but of course it's not his name. So Mike came to me with more than 10 years of rheumatoid arthritis, deformed. And like he was in his late 30s, and he had it since like late 20s. And he was severe RA, high CCP positive, rheumatoid factor elevated, and then the erosion of his joint on his hands, but as well as his hip. So he was wearing a cane. And I reviewed.
Sorry, I remember that a lot of people don't know what an erosion is.
Oh, yes, sorry. So erosion is, thank you so much. Erosion is when you start having your bone. So basically you have the cartilage on top of the bone, and then you start having the bone. So the cartilage first is eroded. So basically less cartilage because of the inflammation that sorts of eats it. And then you can have erosion when there is I don't like the word eating, but basically there is so much inflammation of the joint that the cartilage is removed, or at least at a place, and then there is the bone that's also eaten. Sorry, I hate that word.
It almost looks like when you look at x-rays, because I recently found this amazing radiology website from the Netherlands, by the way, that's patients can look, anyone can look at it, and it almost looks like little holes.
Yeah.
Like you took the bone and you just were like, you scrape.
That's why the eaten.
Yeah, yeah.
But I
So,
hate the word eaten because it's like as if something is eaten, but there's so much inflammation that it looks eaten. That's really, and that's
okay.
really how we call it.
But that's a sign of more severe disease when it gets to emotions,
absolutely.
Right?
And that's a sign. That's actually what we want to prevent. And that is why we do this approach of we don't do the step-up therapy approach, but rather we like treat to target, drug to target, so that if you don't respond to the first line, which is usually methotrexate, we put you on a biologic. So fast forward for Mike. And so Mike had been living in pain and anger. And anyone that has had pain for a long time, look, I've had pain with the surgery, and oh my gosh, I was just like, whew, like patients who have chronic pain, I had suddenly a whole lot of compassion, because it really is painful. there's really a term for that. Like having chronic pain is probably worse than having just one-time pain, like very intense pain. So anyway,
I don't have any hope of it getting better at a certain point.
I know, right?
More and more things. It's like, well, where's the data for me to have?
No, absolutely. That's a really valid point. So this patient, so Mike, had seen, I want to say that he had seen 10 rheumatologists. Yeah, he had seen a lot of rheumatologists. And at the end, you could make out, I didn't say that in the TEDx because you don't have that much time, but basically I could feel by reading the notes that they had fully given up. They were like, whatever, he doesn't do what we want him to do, so we're not even trying. And the person, like he was traveling, and so, yeah, of course, they couldn't do all of the things that they were offering him. But also, like, did they really take the time to discuss? But I'm telling you, like the last ones, you could make out that they had given up. They were like, yeah, whatever, I'm not even trying. And so I asked him, I was like, like, because he was so angry looking at me, and I was just like uncomfortable. And at the same time, I was like, well, I'm uncomfortable because he's probably super angry and he's super upset at rheumatologist. And yet I'm here and I know I can get him better. Like I knew I could get him better because I have amazing treatment. It's not me. It's not me. It's never me. It's the treatment and it's the patient that does the work. Like it's never, ever me. But, when I say I know I can get you to remission, it's because I know my field can get you remission. Right. And I know you can get into remission. And so I told him, I said, look, I think I offered him a treatment, but I went very fast about it. And I was like, honestly, have you ever thought about the fact that maybe this rheumatoid arthritis has brought you something good? And you should have seen his look. He was like about to, like if his eyes were guns, he would have killed me on place, like right there. Like I could imagine like the fire, taking me. And so I didn't see him for 3 months. I didn't know if I would ever see him. I had written him like some treatment, a treatment plan and all this. And I was hoping that he would get it. But he did. And he came back and he had no more pain, no more joint swelling, no more morning stiffness. And he agreed to do a hip replacement and so on. And this is just like one of the most incredible examples, but I have so many of those. But because why is it so important to me is because he came back and he was like, I thought about what you said. And yes, this RA brought me so much good. And he started like enumerating all of the good things that his disease had brought him, which he had not realized until that question, until that crazy rheumatologist question, right? And to me, you could have said, oh, this is a difficult to treat patient. I mean, he's already seen 10 rheumatologists, yet the first treatment I gave him, he went into full disease remission. I mean, the guy I only saw once a year after that.
That's so weird. Why didn't the other rheumatologists give him that treatment?
I think it's him that would not take it.
Oh, okay. Sorry.
Exactly. Right. So it's not like when we say difficult to treat treatment, like he was a difficult to treat treatment because difficult to treat RA patients because he had tried other stuff. Mm-hmm. But Was it really difficult, or was it just that he never fully wanted to be in remission? And it's almost like, so this is I told you I'm metaphysical here.
Would it be want, or would it be believed it was possible?
I think both. I think also this idea of, am I worth it? And do I like, and so this is such a question that I ask on anyone that I'm having an issue with, like getting them into remission. And I'm telling you, I ask this question not that often, honestly, because my patients go into remission easily. But some of them, it's hard. And some of them, it's not that it's hard. Like, okay, sometimes it's like their medication doesn't work. Sometimes it's that they don't tolerate the medications. All right. Yeah. And that is just as annoying from both sides then like it doesn't work. And so I asked them that same question. I'm like, have you ever thought of what this has brought to you? And it's only the moment they are willing to accept that this has also brought them something, in my experience at least, that I see some changes, right? And it's like, wow. And so it's not everyone, of course, nothing is 100%. That's the black and white that you don't have.
Yeah. It would be boring. Like. It would be boring if life was too black.
Exactly. So it's never black and white, but it's so fascinating. Like, do I deserve this? Like, do I like, and what benefit did I get from having my rheumatoid arthritis? Is there any benefit of this? Like, I can tell you my cancer, stage 4, I mean, scary. Yeah. I mean, I got so much out of it. I mean, I'm now here talking to you. I would never have talked to you before because, I mean, I would not have been in this podcast idea. Right. I have, opened my own direct care practice and then now I'm like loving even more being a physician. Like, there are so many good things that happened thanks to my cancer that, like, I want to say, like, okay, yeah, it changed my life, but for the better, not for the worst. And so I'm not saying that everyone is going to have this relationship, but I really believe that there is at least something positive in everyone's journey. And it might be, maybe you get to realize that your husband, like you and your husband have a better relationship now, or anything, right? So sorry, I know I went on this tangent, but it's like, what is difficult to treat rheumatoid arthritis? And sometimes it's like, do you think that you deserve remission is a really, 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 really important question.
And I've seen that a lot in the support groups I leave. I guess I've seen a lot of people who truly do want to feel relief and truly want to feel better and have, have failed, quote unquote, or the medicines have failed them. They're on their 5th one, they're on their 6th one. And it's really, really tough to maintain that sense of hope when every single thing you've tried hasn't worked. So my heart goes out to the people who've had that difficult to treat RA. And when we were talking about language earlier, I really quickly wanted to say, when Dr. Amigues and I are saying difficult to treat RA, this is like a phrase in literature. Like there's an article I'm going to put in the show notes that's from 2022 called Difficult to Treat Rheumatoid Arthritis, in quotes, current position and considerations for next steps. So this is not, she's not saying the patients are difficult. No. And when we say, there's always kind of phrases that can feel really weird as a patient, or also failing. You didn't fail the medicine, the medicine failed you, so knowing all these phrases is just helpful.
I hate those words. Thank you so much for clarifying that. It's not a patient that's difficult. It's never ever a patient that's difficult. I think, from a rheumatoid arthritis standpoint, it's just that it's actually fairly easy usually, like, right? Methotrexate doesn't work, biologic. And honestly, I usually I did a diagram and like a whole explanation of how, like, what you can expect with rheumatoid arthritis. And I'm showing this because I tell my patient at 3 months, if it doesn't work, we switch. At 3 months, if it doesn't work, we switch, because our goal is full remission. Our goal is full remission. So that's, And then what was the other word that you said? The fading. Oh yeah, I hate that word, fading. Yeah. We didn't reach remission. That's the word that we should use. I
like that one too, reaching remission. Or my friend Jatel, who's been on the podcast before, she just says the drug failed me.
For sure.
For whatever reason, it didn't, in your body. And I think I think the fact that if I'm zooming out to the 20,000-foot view here, you really have slowed down and looked at your patients as a real human being sitting in front of you.
Yeah.
And that's honestly like sometimes it's the most therapeutic thing. Like I can usually tell within like 3 minutes of a clinical encounter when I'm the patient with a new provider, whether they're on autopilot, whether they're really taking a moment to see me.
Yeah.
And I think there's something in occupational therapy and in psychology, they call it the therapeutic use of self.
Yep.
If you've ever heard that, but yeah, it's like the value of being seen by
Yeah.
someone and validated. Like when you look at somebody who's had these treatments that haven't worked for them and you say, I still want to help you aim for remission.
Yeah.
It's just a beautiful thing. And I'm going to ask you selfishly, I'm going to ask you a question for me, because I do think, I wonder, or I'm curious, is remission, you said you aim for remission in all of your patients that for sure have RA. Once you kind of are getting, do you ever get to the point where you've exhausted all the treatments? Like
Never.
I'm on the 5th biologic and I'm worried about running the clock out.
Oh yeah, there are so many of them. Don't even worry about that.
Okay.
Don't even worry about that. So in other diseases, there are some other diseases where there's not that many options. But when it comes to RA, we have so many options and they keep coming back. Like we keep having new ones.
Well, that's true. There's only 3 when I start out, 3 biologics.
Yeah,
So we say
exactly.
biologics, it's just a class
Yeah.
of medication.
Yeah.
And then
And
now
I want to share this because I want you guys to realize this. I take the example of rheumatoid arthritis for my own cancer journey because I got diagnosed with this stage 4 and it's HER2 positive breast cancer. I'm going to put it in the past because words matter. It was HER2 positive breast cancer. And the HER2 is this receptor. And so the same way that, rheumatoid arthritis may have this positive CCP, like it's kind of like the same concept. And so I had a biologic and I still take a biologic every 3 weeks. I mean, I'm really expensive patient because I'm worth it,
Oh,
like
me too.
Exactly.
We're both really expensive. Cancer
We're
and
so worth it. We're so worth it. But it's really interesting. So when I go for my PET scan, and because I need to do PET scan every 6 months to make sure that this thing doesn't come back, right? I always, to reassure myself, like literally, this is what I do to reassure myself. I'm thinking, what do I tell my patients with RA? And I always think, well, this was the first line. I got into remission with the first line. But even if it were to ever come back, there are many other options. And so that is literally what I tell my patients. And that reassures me as a patient with a history of cancer. And so if that can reassure me as a patient with a history of cancer, I want to make really sure that you can all be reassured by the fact that like we have unbelievable treatment in rheumatoid arthritis. Like it's so cool, right? Like when I started rheumatology, we were starting to use TNF inhibitor. Right, like it was Remission.
That's
exactly the first biologic that in rheumatology, because there were other biologics. But it's like, the change of like in my lifetime, I'm not that old, guys. I'm not that old. And like seeing that difference. When we say we aim for remission, we really mean it. It's not the same thing than just aiming for minimal disease activity or for moderate disease activity. And so, yeah, I believe in what I say because that's really what we aim. You can ask all of my patients, I aim for remission in all of them.
Right.
That doesn't mean that you're not going to flare. That doesn't mean that you're going to be in remission forever, but that we're still aiming for that goal with the idea that hopefully it's going to last forever. Forever, right? And I think that's what's really important is to realize that we are changing, our bodies is changing, our hormones are changing when we are women, and like the environment stuff are changing, right? And so it's not just black and white, and it's just like you go through a journey and your rheumatologist is on your side to get you to full remission all of the time.
Well, and yeah, I honestly, how you explain it to me is exactly how my rheumatologist did in 2003. And I was kind of shocked the first time after 6 years. Then whatever my body, I think the theory is that my body created antibodies to the medicine because I had my first post-diagnosis flare up. And I was like completely shocked because I was like, no, this is the plan. I thought it was kind of like diabetes, where like there's the one thing, like there's insulin, right? For diabetes, it's like there's the thing. I take this TNF inhibitor, I'm gonna take it forever. And so, it's a helpful lesson to learn that, it, like you said, it is a journey. And even if the goal is remission, the strategy to achieve the goal might have to change. To say, you know what, this medicine, your body is not responding in the same way as before. Let's switch you. Like that was actually, this is going on another topic, but in terms of coping and mental health and acceptance, that was actually significantly harder for me to cope with than the initial diagnosis, because the initial diagnosis, I felt so much relief because I had been medically gaslit, and that's a whole other story. But I felt like, oh, okay, this is what I do. Like there's a diagnosis, there's a treatment plan. They believe me, all good. And then when I had my first flare up, I thought it was like that moment of truth of like, oh, this isn't just one mountain I'm going to climb and get back down. It's going to be a series. And that is kind of a metaphor for life, right? Every time you think, oh, I just do this. It's like a thing. It's like, I figured it out. Oh, then they change.
Yeah. And I think I hear you. I really do hear you when you're like, you've done so well. And then suddenly you're like, wait, what? Like, where's my truth? Like I come up with this idea that I'm good with RA and wait, what? Like it's not working anymore. So I'm with you. I think that as a rheumatologist, I see so many good drugs that I'm like, yeah, no, so maybe that's like something that I've learned, because I was like, I got you. Like, it's okay. Don't worry. Like we have amazing.
The next one. Yeah.
Exactly. Yeah. But you're like, but hold on, this one was working. Why is it not working anymore?
Yeah. My rheumatologist, she's really shy, so she doesn't want to come on the podcast, which I totally understand. Also put her in an awkward position. But she says that it's just, I don't know if you'll relate to this. So I thought it was really cute because I told her maybe one day I could go back on that first TNF inhibitor. And she goes, a lot of people, when that first drug that put them into remission, it's like your first love or like your first boyfriend, where you're like, oh, like she said that you kind of romanticize it in a way, and that, there are possibilities of going back on one, but we kind of want to go to the different classes first.
Exactly. Yeah, exactly. So that's the beauty, right? Like in the TNF inhibitor, there's like 5 of them. And then now there's the biosimilars. And then you have all of the combination with the conventional drug. Like there is a reason I easily say we aim for disease remission, because it's not like we only have 1 or 2 drugs.
One more thing before we go to the rapid fire questions. And I'm so grateful for you for spending this time, because this is an area of real confusion for people. I do know that like I've talked a lot in the Room to Thrive, self-management support group about like choosing where to put our energy, like how much energy to put into making things quote unquote better, making my pain levels better, fatigue better, and then how much energy to put into adjusting and adapting, like to maybe this is as good as it gets for today. This is as good as my pain's going to get. Can I adapt to that? Can I still find ways to, do those meaningful activities? But sorry, that was a little tangent, but
that's good.
The question I was also thinking about before that was if something I think is confusing to people is where do let's say their doctor had told them or they had the impression that maybe remission isn't really achievable for them. What would you say would be, like, you mentioned kind of like a decision hierarchy, like you start with the medications. Where do the lifestyle things fall in with that? Like, do you do it alongside? Okay. So what are some of the more helpful things?
And because I don't want to finish before explaining one more thing. So I'm going to go back in the disease remission. No, I just realized, I was like, oh, I really want to make sure that everyone gets that. When you have a quote unquote so-called this difficult to treat RA, there is one thing that I would recommend, is to make sure that it is indeed RA.
Yes.
Thank you. That's like a really important one. And why? Because not all drugs for RA work for the other conditions. So the truth is that insurance are a problem in this country. and that to get medications, if you say that someone has RA, they get a lot more access to a lot more medications, okay? So rheumatologists have a tendency to say RA to a lot more things that are actually not necessarily RA, and the problem is that, sorry, I'm laughing. You may see one rheumatologist, and then you may see another one, and then you may see another one. Maybe you see a nurse practitioner or PA, and that diagnosis of RA that has been written just to get some potential treatment gets carried away without being thoughtfully thought. Like, is this really RA? The reason I say this is,
yeah, sorry. I've seen that in some of the patients in the group, and they'll say, my doctor outright told me, we're not sure if it's RA, but we're going to say it's RA so you can get the medicine.
It's absolutely. And so if the doc has the time to explain this, that's great. Sometimes they don't, right? And I've seen, or sometimes you do not know. And so you just like, I've said to patients, like, look, I'm not completely sure, but this is clearly inflammatory. If I say this is RA, you have access to more drugs. So bam, we're saying RA. But I've seen rheumatoid arthritis not being rheumatoid arthritis, but being gout or pseudo gout. Super common to be pseudo gout. I've seen it to be psoriatic arthritis without psoriasis. And so one of the reasons why rheumatologists love their specialty is that it is not black and white, and we are the detective. But it's really interesting, right? I can give you how much, whatever TNF inhibitor I want, you will not respond if you have gout. Like, I mean, you shouldn't really respond that much if you have gout. You may respond if I give you anakinra, which works both for RA and gout. But you see, like all of those things, so I think that that's really important. For PMR, same thing. It doesn't work TNF inhibitor, but so polymyalgia rheumatica. But like it would, like, you know, tocilizumab would work. And so then maybe someone would say, oh, you have RA just because prednisone and tocilizumab works, because that works for PMR. So all of this to say that I think that if you have a difficult to treat RA, we have to also make sure that we pause enough and we look, is there any other thing going on? First of all, is my diagnosis correct? Second of all, is there anything else going on as well? Like fibromyalgia, which is like small fibers neuropathy in most of the case. So anyone that gaslights you with fibromyalgia, just tell them to learn about small fibers neuropathy. All of those things. And I think that that's really important. Depression and so on, and vitamin D deficiency and all of those things. And I think that that's really important. Like, did someone actually do an MRI or an ultrasound to see if your RA is really active? So I just wanted to put that point, which is that we need to make sure that we know what we're talking about when we're saying that the disease is not in remission, because you may still have joint pain if it's not RA, but osteoarthritis. You may still have joint pain or muscle pain if you have fibromyalgia. You may still have fatigue, and you may still have, so many other options. So I just wanted to share this because that's important. Now, for the lifestyle question, 100% I add them at the same time. Like, I mean,
why not?
Exactly. And I think for me, like, again, as a patient, I mean, lifestyle changes are literally in your power. They are a way to empower our patients from the moment that they have a symptom. And so you don't have to wait for your rheumatologist. You don't have to wait for your blood work. You don't have to wait for the x-ray. You don't have to wait for anything, and do all of those techniques that are clearly proven scientifically to work. You mentioned exercise for fatigue. I mean, it's proven in cancer. That's like the only thing that helps with patients undergoing chemo and being tired. It's exercise. It's crazy. Right. Like, you're like telling patients, exercise.
And it also really, really helps with sleep quality. I was thinking about doing a little post that was like, 5 reasons to exercise with rheumatoid arthritis that have nothing to do with muscles and joints. Like, because it's really not even just that. It's emotions, the endorphins that get released. Yep. It's the fatigue. It's the improved fatigue, improved sleep quality. Yep. And obviously improved pain levels. So exercise. Yep. And I do think that it's lifestyles in our control to a certain degree. I mean, obviously for some people, there are going to be barriers in terms of, let's say you're a mom to like 3 small kids, or financial barriers. I think that's one of my pet peeves in the nutrition space, when people are like, it's totally in your control to eat like a wholly, like organic, like perfect diet. It's like, okay. But, it's not in a lot of people's control to maximize everything, to get to get therapy every week and meditate every day and exercise every day. You might have to pick and choose,
Totally.
experiment, as I'm sure with which
Yeah.
one's going to give you the bang for your buck.
That's exactly right. And I think whatever works for you. And the thing that I always tell my patient is that if you're going to be frustrated about any of those, like, it actually defeats the purpose, because the frustration is going to cause inflammation. So don't be frustrated. And in terms of exercise, movement is a better word, because it doesn't actually have to be exercise where you sweat. It can just literally be movement, which is just walking. Just
or dancing.
Oh, dancing. Oh, I love that. Yeah, dancing.
I
Love
know.
it.
We were talking about Twitter earlier. I once saw a doctor on Twitter that was berating their patient. He said I asked them if they exercise, and they said that they walk the dog for 40 minutes every day. And they were like saying that that's not real exercise.
That is.
I know. I was like, excuse me. I get it that, like, I will say for RA, I do think of like the 3 pillars as strength training, cardiovascular, and stretching. So if you're only getting cardio and not strength training, you're missing a little bit, because you do want to challenge your muscles, not just your heart, and vice versa. If you're only doing strength training and not, getting your heart rate up, it's not quite as good for the cardiovascular effects. So having a little bit of both is helpful. But yeah, I mean, I think I know it's kind of a leading question to say, like, do you do the lifestyle alongside the medicines? But it's so often posed to patients as an either or instead of a both and,
Both and exactly. I love it. Like, why deprive yourself of a technique that's going to work and that, doesn't really cost much. So yeah.
Exactly.
Exactly.
And I'm glad you mentioned it, because I have no negative association with the term exercise just because of my background as an athlete. But I know a lot of people get intimidated by the word exercise. So I remember I heard that from a physical therapist too. Always say like movement opportunities, or they even recommended like movement snacks, which I thought was cute. So like at the day, like not thinking about it as like going to the gym for like an hour, but thinking, okay, like if I'm going, can I go up and down the stairs on my way to a meeting for 5 minutes, just to kind of get some more activity in. So it's so helpful. Well, I mean, I feel like we could talk forever. We might have to do a part 2, because I think remission is such a fascinating and like complex topic, and just the topic you introduced of like, maybe your diagnosis is not accurate. I don't want people to freak out about that, but I do think it's important to recognize that it is common, or it is not a freak occurrence for diagnoses to change in rheumatology, because so much is gray areas, like you mentioned. So you had nicely sent me a couple of links. Like one of them's called, like, from a journal article from 2021 that says, is seronegative RA true rheumatoid arthritis, a nationwide cohort study? So people can learn more. Because it is, I once had someone in the support group who got their diagnosis changed from rheumatoid arthritis to psoriatic arthritis. And they were like, initially like emotionally coping with that. And it was kind of a funny, like, the devil, right? When you first get diagnosed with RA, she's like, I don't want this. And then now she had RA, she's like, well, wait a minute, I was just getting used to that. Now I have a new one. But I remember telling her, it's really, really important to know what your condition is, because this is going to open you up to the right treatment. You want to match the right treatment to the right disease,
Totally.
So hopefully that, if you're, and that's why I think second opinions are always a good idea if you're feeling like there's something missing from your current, plan.
Mm-hmm.
Okay. So a couple rapid fire questions that, knowing you and I, we could probably talk about each of these for an hour, but because we're so passionate. But what is some of your best advice for newly diagnosed patients?
To find the best rheumatologist for them, because it's going to probably be a lifelong relationship. So find the best rheumatologist and like make sure that you trust them. Yeah, that would be like the number one. Number two is to realize that it's okay. Like, rheumatology is a really cool field where it doesn't have to be sad. It's a happy field.
Yeah. Oh, that's a great one. That there is hope that this.
A lot.
Yeah, of course. Yeah. And what is something, it doesn't have to be clinically, like, what is something that's been just bringing you joy lately?
Oh, so much stuff. Sorry.
I know.
No, so much. I mean, I would say that one of the reasons I love being a rheumatologist is to see my patients in remission. There is like a huge rush of dopamine when it comes to that. So that has been wonderful. That is wonderful, and it's ongoing. What has brought me joy? seeing my kids play the piano. I thought I had given up on them, and then the other day they were like, my son was like playing with two hands, and I was like, wait, he's actually learned something, and it didn't seem like he was learning anything. So I was like, wow, okay, cool.
Oh, how old are they?
They are twins, and I have almost 8. They are 7.
Oh, okay. That's so, yeah. Charlie, my 9-year-old, has been doing piano too. And
Yeah.
it's wonderful. Yeah, when they have that, and I think piano is a great frustration tolerance activity
Yep.
because you have to experience your mistakes,
Yeah.
and so yeah, that's beautiful. And then last rapid fire question, but again, long question potentially, but what does it mean for you to what does the concept mean to you to thrive with rheumatic disease or rheumatoid arthritis?
I think it's if you're not letting it define you. I think it's a component of you, but it doesn't have to define you. It's
Mhm.
not because you have RA that you're RA, right? Like it's not because you have pain that you are pain. Um,
Mhm.
and so I think thrive is just living your life to the fullest, living your life without worries. Because, and I'm going back to, because I'm a rheumatologist and that's what I tell my patients, I want to worry for my patients so that they don't have to worry, so that they can live a full, normal, and full life. And
Mhm.
normal, sorry, we define that, but
Oh, no, no, no. It's okay. It's totally one of my
like
little.
their life, I want them to live their life. I want them to be able to play with their grandkids. I want them to be able to crochet. I had this patient who sent me how do you call that, a hat that he had needed, and it's kind of funny that it is a man, but like he couldn't do anything, and then suddenly he's able to knit, and like he's so grateful, and I got a hat in the process, yay. you know
Oh, there's so many artistic people with rheumatoid arthritis. It's really, I
yeah
mean, I'm blown away a lot. And that's one of the things that people grieve when their disease isn't well controlled is I can't do these activities I used to want to do. You love doing like watercolor painting or, you know,
yeah
or yeah, crocheting, knitting, cross stitch, just so
yeah
many arts, talents. So
And I will say it again. I'm gonna. This is like a hill I'm willing to die on.
yeah,
We can get you to remission because it's true. Because it is true. You should not have to give up crochet. You should not have to give up painting. Like
if
we
it's
are
just
not.
RA, yeah.
Yeah, and even if it's another rheumatologic disorder, like we just have to find what it is, and
Mhm,
then we treat it. Like there's a reason I did rheumatology twice,
mhm.
guys. I love it because we get our patients into like ability to do everything they love. I'm not saying the 90-year-old, I think I put I did put an 88-year-old recently on a biologic, but because I was like, well, you cannot do what you like. So what's the point? So do you want to just try? Like, let's just try. And it's
Mhm.
not because I'm trying that we cannot back it off. We cannot always back it off.
Right,
But
right.
yeah, there are
Well,
some patients,
and I
like,
think there are yeah, and I think again, it's still a balancing act in the meanwhile while you're waiting to get to that point, or if for whatever reason, maybe it's because you have a deformity or you have another condition like a musculoskeletal condition that's like, making it difficult for you to do things. Like let's say there was someone in the support group recently who's really into rock climbing. Like there might be a point where you're not going to be able to climb the things that you used to be able to climb, but can you increase your ability to enjoy the activity in an adaptive, and this is me being an OT, but an adapted or modified way, or find a substitute activity that kind of scratches that same itch, because then that way your life enjoyment isn't dependent on full remission. So it's kind of you can get at it from
yeah,
two different
yeah.
angles, and just put all the possible tools in your toolbox. But
But yeah, it's really interesting because and I think the difference is that you're OT, so you don't actually offer the treatment. But like I'm a rock climber. If you remove rock climbing from my life, I would be so miserable. I would be so sad. It would be really
yeah.
sad. So
It might happen though if you got like a spinal cord injury or something, like
I know,
yeah.
and you're right, and I love that you're sharing this, and that's why I love occupational therapists.
And
Because
we're always like trying to be creative,
yeah,
but
I know. I love it. I love it. Yet I would say that it's really cool to do this. And there's a reason why rheumatologists are rheumatologists and we have a lot of options. And I would not give up. Like I would say don't give up. You can. I would still say, yeah, we're gonna get you to climb. This is
Yeah.
not a spinal cord injury.
No, no,
Yeah,
no. Of course. I'm just thinking about a lot of the people in the support group have like multiple comorbid
oh,
conditions.
okay,
So, it might be that RA is not their only barrier.
got
But
it,
they have other conditions,
got
concurrent
it.
and
Yeah,
stuff like
yeah,
that. But
yeah.
so that's like stage 2 thriving is like being able to thrive when you're not able to fix the underlying problem. Can you still, you still have a life. You're not in a coma,
Yes,
so that's why I kind of like give
yes,
myself that pep talk sometimes,
yes.
because like I had some acute injuries on top of my RA that really interfere with quality of life. I re-aggravated my neck after a car accident injury.
Yeah,
I sometimes retweak it. It just takes a day or two to get settle back down.
yeah,
But there those kind of things pop up, that are not, they don't
yeah.
have like a fix. But
And it's a really powerful thing to just say, hey, yes, I'm aiming to be better. Yet I also need to listen to my body, and I'm gonna work with it. And
Mhm.
right now, my neck is turned like whatever, or my joints are painful and swollen. So yeah, of course, I should not rock climb on a painful and swollen joint because I'm
Right.
gonna aggravate it. So I think that there's this fine balance of you can have your rheumatologist aim for perfection for you, and also you listen to your body and adjust to what you can do. I think that there is this fine balance in between.
Yeah, yeah, 100%. And there's analogy of that is for me, or the thing that this is a whole other topic, but the acceptance and commitment therapy was really helpful for me because it's like, okay, life is like whack-a-mole, right?
Mm.
Challenges are going to come up. Maybe I whacked the mole. Do you know that game? Some of us, if you know that game from France, but it's that game where there's little moles that come up and you have a mallet. It's a
Oh,
and you hit them. So they come up one at a time. Doop, boop, you hit it, but life, there's never going to be or at least for most people, I think the human condition is that we are going to have to approach suffering at some point, whether it's psychological suffering, the death of a parent, like things that are just normal part of life that are difficult for us to cope with, and building a capacity to cope is a good thing. Whether or not you end up whacking that mole of rheumatoid arthritis, you're still going to have to build the skills to cope with, other kind of, like for me, one of the moles, like little animal guys that came up was like the car accident. So the skills I had built as like a chronic illness patient actually helped me cope with that. Probably for you the same way that the skills you built as, cancer patient is, are helpful too. So that's kind of why I try to take
yeah.
sides. But of course, I'm always like, I'm the biggest. I feel like I've actually gotten comments where people think that I'm like getting paid by pharmaceutical companies to talk about how effective the medicines are. I try to be always clear. I'm an occupational therapist. I'm not a doctor, but I'm an RA patient who's taken these meds, and these meds, the prognosis for me without these meds would be that I wouldn't be able to be, swing dancing at my wedding. I wouldn't have been able to be, still able to, coach my son's soccer team and do things like,
Yeah.
I'm always kind of trying to
Yeah.
counter the misinformation online or the medication fear and medication shaming that
Yeah.
occurs. Because,
Yeah. And you're in that space. And yeah. And I would love to talk about that actually. Yeah. I think,
oh yeah.
yeah.
Well, okay. So, I'm putting all these, links in the show notes. But can you just let the audience know where to find you online?
Yes, absolutely. So the practice that I have, and that's also like a movement, is called Unabridged MD. So
I
it's
love
unabridged for the non-edited version of the patient and the non-edited version of the physician. So Unabridged MD. And I do have the podcast Unabridged MD where I talk all about health. And then I created a YouTube video called a channel called Rheumatology 101, where I talk. I just love rheumatology. So I was missing educating my students and fellows. And so I'm like,
Yeah.
oh, I'm just going to do a YouTube video channel. So Rheumatology 101 by Dr. Isabelle Amigues. And then Unabridged MD. And I have like Instagram. That's actually how we met, right? Instagram,
Yes.
Twitter, and LinkedIn, and all of the usual platform. I think there's also TikTok, but I'm not really on there.
Yeah.
So yeah, but
I get you
Unabridged
on there.
MD,
It's
yeah.
so fun. No,
Yeah.
there's a lot of patient education on there. No, but I just subscribed to your podcast. I mean, your podcast, your YouTube channel as we're
Oh,
talking. So I love that. Rheumatology 101. It's so needed, you know, that there's
Yeah.
so much confusion out there. Even though there are some great websites, people still seem to get really confused. So I'm really excited that we got to talk today. So I hope
Yes.
people will follow up with you if you're lucky enough to live in Colorado. Maybe they could, see you because people are always asking me for recommendations for rheumatologists, and it's hard because I'm in Seattle, so I know the ones around here and I've met some at the conferences, but it's nice to have that personal touch. So thank
Yeah.
you so much.
Thank
And
you.
and your TED Talk, is your TED Talk available? That's what I was gonna
Not
ask.
yet, because I
Okay.
just gave it. Yeah, it's changing the relationship to our health experience. I don't know if I'm going to change the title, but I think it's coming like in 4 to 6 months, so we have time.
Oh, months. Okay. So I was gonna say I put that as a placeholder. So I will say to link when available, the TED Talk, because I think and I love that you have this tagline I've seen you use, like remission is my mission. I love that. I think that's really cute. Sorry. So I appreciate your take on remission. It definitely gives people a lot of hope. So we'll sign off for now, but maybe we'll do a part 2 later.
Yes. Thank you so much. Bye.
Bye.